Hello, everyone.
Hello.
Thank you very much for being here. Karen will introduce this webinar in a second. Karen, can you hear us?
Yeah, I can. I'll start now. Right, good afternoon. Thank you all so much for joining us this afternoon, as I know how busy all you vets are and have been over the last year. My name is Karen Simpson-Jones. For those of you who have not met me, I am the owner and manager for VetLig and have been since 2010 when I created the company. In 2001, I was working for a human orthopaedic company as their global manager for the sports medicine division of the business, which included artificial ligaments. These were used in the knee, the shoulder, the hip and the foot, and were implanted actually into many famous sportsmen and women, which got them competing back at the top level of sport quicker than conventional repairs did. These included Olympians and premier footballers and also rugby players. In 2008, the idea that these same ligaments could benefit animals in a similar fashion was born. Thanks to having some vet friends who could introduce me to referral centres, we created a smaller version of the ligaments and started trials. We started with the Achilles and patella at Davies Referral Centre and Liverpool University with Mark Morton, who did the majority of the tests and publications on this ligament. They also implanted a series of CCLs in 2009, along with Dr Barnhart from the USA, using Securos as they were our distributor at that point. What this showed us was that the ligament, as it was, needed refining. With the technique and the fixation, it needed to be altered. We needed smaller but stronger ligaments without free fibres that served no purpose with these chronic cases that we were trying to fix. I first met Victor in 2015 and he formed Novatech in 2017. And with his team from the University of Lyon and existing veterinary ligament users, they redesigned the old style Lars ligament and redid all the publications for the application for the Achilles, patella and triceps. We needed to prove that we were as good, if not better, than the old system that we wanted to replace. And we did that with flying colours. We added new applications such as the hip and added a suspensory device in the form of the Buttin ligament that you're going to see today. And we made sure that all the instrumentation could be used across our portfolio as it's a modular system. The intra-articular CCL in one version or the other has been used across many countries for over 10 years now. Some use it arthroscopically, but most use it open with the smallest incision as possible. I first met Dr Butitn quite a few years ago. We can't exactly remember when we first met, but probably about 10 years ago. And he's been an early adopter and user of all the ligaments I have sold or been involved with, and obviously now that Novatech has refined. He is involved in the ongoing clinical studies, so he's the perfect person that can give an objective view on what it is we're trying to do with the CCL and the hip ligaments. I hope you enjoy the webinar and that this gives you some background into who I am, who Novatech is as well. We're a small but determined group trying to make a difference and give options to our vets to give to your patients. As a group, we're adaptable and we can partner with you vets to try and get the best outcome we possibly can. So any questions, if we can't answer them at the moment, then please do email or call if you'd like to know anything else. And if you're watching on catch up and you can't obviously ask questions at the moment, please email me. So without much ado, over to Dr Buttin. Thank you so much. And it's in your hands.
Okay, thanks, Karen. I think you mentioned something very important, is that we have continuously ongoing modification of the techniques just to be better and better. And so that's why we really love this, because it's a developing thing for everyone, for all the team, all the group. And I hope you will enjoy this, because it's something really new, of course, but we hope the best for the future with this technique, really. So I will share you my screen. Okay, and so you will get here, so I will shut probably also my video. Just to be sure that you get all the information of this. So you have here the ligament and tendon reconstruction with synthetic ligaments, and we are going to talk first of all of the material, you know, the implant. We have different kinds and different type of implants that Novalig, Novatech Surgery and Novalig are sending to you. We have the Novalig, which is something that we can use for ligament repair, as cranial cruciate ligament rupture, of course, but also for hip replacement for some of them. You have also the Novalig with Buttin, which is really interesting because this is adding and simplifying the technique sometimes, and adding also some security. So we decline these ligaments into different force resistance, in fact. So one will hold until 4,000 Newton, the other 8,000 Newton for the Novalig, and the Novalig with Buttin will hold 2,000 and 4,000 Newton. So you will quickly understand that this is really above what nature will have on the native ligament. So this is not a problem. Probably the ligament will never be a problem for holding and for the resistance, but it will be a different kind of problem with the interference. So the most important thing that you can see is that we have really an innovation here with this material. It's ultra high molecular polyethylene, which is a biocompatible grade. And we decided here not to use free fibers for different purpose. You will see that because of arthroscopy, because we know that we can have gross colonization when we don't have the fibers. It's superior when we don't have them, and also for anatomical variation. So the really big innovation of this implant is the accrued resistance with a thinner ligament. So we will be able to implant this in a very, very small dogs and cats to the bigger dogs that you can have in your practice. It's really good because we have an abrasion-resistant implant. It's 3 times stronger than polyester, and it's rigid but malleable. So it's possible to manipulate it as we need for the surgery. Before this implant, we have the Lars, which was an implant that came from the human practice, and we have a bigger ligament because the resistance was inferior. But the very big problem with that was that we had a really big bone tunnel to do, and that was a risk when we have smaller dogs, which could be a fracture, of course, and also sometimes it was very difficult to pass the prosthesis through the bone tunnel. So again, we decide not to use free fibers because we have minor importance of colonization when we have them. So when we use our new ligaments, the colonization is better. We have the chance to be easier in implantation because of individual variation. So when you have a joint, of course, the intracapsular distance of the implant will never be the same. So it's always difficult to define the length of free fibers. So that was for us something that would lower the versatility. And so we are very happy with this new technique. Also, we know that this old ligament had a very high percentage of prosthesis slippage, as it was reported in some cases, in some papers. So the challenge that we had to go through was to define and to be sure of the isometry, of course, of the ligament. We need to have a complete range of motion, and the movement must be completely free. We want also reproducibility of the technique. A good technique is a technique that everyone is able to do, of course, if we teach them. So we need also to define the fixation, the position of the tunnel, the number of the screws, the position of the screw. So everything will be given to you in this conference. So this implant has better resistance, as I told you. We have no implant rupture to date, as far as I can know. We have a smaller diameter that permits to have patient that weight very, very light, and we have also a very big versatility of possibilities. It's not only cruciate ligament, but you will see that we have a lot of different possibilities to use this ligament. So the main idea is the prosthesis interface between the implant, the screw, and the bone. It must be sufficient, but it must be atraumatic for the implant. So the screw must not cut the implant, of course, and it must remain, this interface must remain stable in time for all the life of the patient. The instrument, so the screws that you will have to use we have a lot of different diameter now. So we are from 3 millimeter to 6 millimeter, and we are going to have the 2.5 millimeters in probably this year, hopefully at the end of the year. So you will understand that these instruments are a little bit new for veterinarians, because we are not used to use cannulated drill bit, also cannulated star drive, not star drive, but screwdriver, etc. So you will have to see how it works. We need to use a bone tunnel with a cannulated drill bit that will be from 3.6 millimeter for some of the screws, for the 5 and 6 millimeter, but for the 3 millimeter cannulated drill bit, we'll have to use the 4 and 4.5 screws, interference screws. So here you can see the ratchet cannulated screwdriver, which is very, very nice to allow us to easily keep the axis, because you really need to be very precise when you implant any screws for the interference screw, because you might go in the wrong direction. Why? Because we are most of the time in the epiphysis, and the epiphysis is very weak bone, and if you misdirection, you have misdirection, you will continue in this misdirection until you get to the other side. So be very, very cautious with this. It can be simpler if you use a smooth K-wire that goes into this cannulated drill bit, and that will go through the bone tunnel and guide you. But of course, if you have a very big misdirection, you will pinch this K-wire, and that will be a problem to insert the interference screw. You also have hemming guides with a hook dedicated by pathology. For the cruciate ligament rupture, we can use a tibial hook and the femoral one, as you can see on the picture. So as I told you, we have different cannulated drill bits, but we have a K-wire that must be implanted before, of course. And we have also K-wire with a drill bit at the end, which is now better because it's really easier to insert and without any high temperature at the level of the bone. Anyway, at any time when you're drilling, of course, it's like any orthopedic surgery, you have to put a lot of saline to be sure that you just lower the temperature. We have also one of these tool, which is very important. It's a wire passer with a little tube that will allow you to go through the bone tunnel, and this will allow you to take the implant through this bone tunnel. Okay, so the principle, as you know, of any ligamentoplasty is that we need to restore stability. So for this, anchorage must be really good, and that's the interference problem. We need also to have a very good range of motion, so the amplitude of the joint must be completely free, and for this, isometry must be perfect. So that's why you have to have a really good technique during surgery. And we need to preserve from secondary osteoarthritis. That's why the stabilization of the biomechanic is really important to avoid any inflammation that could go forward. Okay, so as you know, we are going to treat about the cranial cruciate ligament. You know, as everyone knows, it's the most frequent orthopedic pathology. For cranial cruciate ligament, we know that for many dogs, it's a progressive degenerescence of the cruciate ligament, and mainly appearing after 4 years old. And we have 50% of dogs that do cranial cruciate ligament disease that is going to do the other one, the contralateral one, within 2 years. The function of the CCL is also very important, and that will convince you maybe that going to this new technology and this new technique is probably superior to TPLO, because we are going to try to stabilize any function of this CCL. So we have, of course, a cranial caudal instability that you can define when you do the tibial drawer. But we also have internal rotation and valgus. And so going for a repair of the ligament is really nice, because we are going to avoid any of these instabilities. And this maybe also could avoid meniscal injuries. So the necessity of surgery, of course, we want stability of the stifle. We want to limit the arthrosis, the osteoarthritis, and meniscal function lesions. We want to restore of course, the function. And so what is ideal? We would say that in human, everyone knows that it's a state of the art, and the biomechanical logic is really evident, you know. So we want to restore every instability, as I told you. We want also to have the possibility to go for arthroscopically approach. The advantage that we can define for synthetic ligament is that it's ready to insert. So that's very convenient and very easy. We don't have any prep to do this. We have an instant stability. It's not dependent of bone healing. It might be important to have a fibrosis anyway, that will appear probably for the first or 2 months. So it's there is something wrong in this dia. So we want also to have the less meniscal lesion, as I told you. The disadvantage might be infection, because it's not something from the body of the dog. So if you get any infection on the implant, you will never be able to remove it. So at one time you will have to remove the implant. So surgery time for now probably is a little bit more than TPLO, but as every technique, we have a learning curve. For me now, it's less and less, and probably approaching TPLO time. But it depends of how long you do a TPLO, of course. So indications and selection of the patient is a bit easy. Of course, it's we want this for any chronic or acute cruciate ligament rupture. We want adult dog, never on growing plates, so never on a puppy. We want, for most of the time, we prefer that the bone density that you get on X-ray is quite normal. We should avoid any infection of the skin. If you have any infection, you should do the surgery later, probably. We would say, but we are not sure, that probably the tibial slope above 25 or 28 might be not ideal, because you will have more tension of the implants. We did some implantation on patients from less than 5 kilograms now and to 80 kilograms. Ideally, we would say from 10 to 50. Owners should be able to observe all our recommendations, so we should have a good talk with them to tell them all the post-operative recommendation, to be sure that they will be able to do it. Otherwise, you should avoid probably the surgery. And probably you should also listen to them, and if the dog is really a mad dog that will never listen to their owners, probably you should avoid this dog. So we wanted to do, first of all, a technical study it's a kind of validation of the steps of the operative technique. It's a kind of risk analysis of every critical point. So we are going to define, first of all, the preoperative preparation. So as you can see here, we are going to put four drapes, then a big drape, and a drape that is on the skin, and then we are going to suture the drape to the skin. The very important thing is that we don't want any contact between the implant and the skin, because otherwise you could have an infection. So please be very, very careful with this. And for those who do some total hip replacement, please use the same technique for asepsy. So the surgical approach here, we can show you that we can do a little medial TP-low approach just to do the arthrotomy. We wanted to show you here the femoral tunnel. So we did a scanner, the CT scan evaluation on cadaver, and we tried to define where would be the best implantation on the femur for the cruciate ligament, the cranial cruciate ligament. So we see that most of the time it's more or less between 60% from the cranial part of the femur at this point. So we would recommend. So here is another CT scan view. To be sure to have the best implantation at this point, we recommend outside in drilling, just because this means that you are going to use the guide that we designed, and that will allow a better spot for the anthesis of the cruciate ligament on this femoral part. So as you can see here, we want outside in for the drilling, but we will do, as you will see, most of the time, an inside out insertion of the interference screw. So it's essential, of course, for this isometric point that you respect this. We want to have an aiming guide that you can see on the bottom of this, on the diapositive. So this is allowing a very, very high repeatability when you use this guide. We tested it, and we find, of course, that it's necessary to go for arthroscopic technique. We first of all are going to show you how to do it open surgery, because it's probably a little bit difficult for beginners with this technique to go straight forward to arthroscopy. So here are some diapositives, some pictures that can show you how it works. You can see on the guide here that we have the distance that will be, in fact, the length of the screw. So it's very, very nice, because you put your hook inside. You can do it also arthroscopically. I've done it already, and it's quite convenient. And then you go for outside in drilling of the K-wire, and you will see, in fact, very quickly how to position the guide because of the length that will appear on the guide. So here is how it works. Then we can put the cannulated drill bit upon the K-wire, and it's going outside, as you can see here on this cadaver. So now we are going to talk about the tibial tunnel. We need also to define the anthesis of the cranial cruciate ligament, and you will see that it's caudal and cranial to the horn of the meniscus, and it's cranial to medial to the intercondylar eminence. So we confirm that with CT scan, of course. So you will see that most of the time when you have your tibial slope here, most of the time the screw will exit approximately to the cranial part of the tibial slope, tibial plateau, I will say. So it's easier if you use the aiming wide again. If you want to have less difficulties, you should not exit too cranially, because cranially the bone is very, very flat, and it will be very difficult to insert your K-wire inside the bone. So if you go a little bit caudally, I would say more or less as where you do the cut of the TPLO, with the TPLO saw, you cut also the end of the collateral medial ligament. So the exit here should be around the end of this collateral medial ligament, and it won't cause any problem, of course, as you know, because the anthesis of this collateral medial is very long on the tibia. The tunnel entry should be close then to this anthesis. The aiming wide again is required if you go for arthroscopy. So again, so when we put here 50-50, in fact, it's not 50-50, it's a little bit on the side. And so you will respect this, of course, if you do a proper examination before drilling. And you put also your hook inside, as you can see on the right picture. And again, this length that you will have as an interference screw that you will need further in the technique is reported here, so that you can read it already on the guide. Of course, you can use also depth gauge. I would recommend to do it anyway, to be sure to have the right measurement, just because sometimes you are not completely to the plateau, the tibial plateau with the hook. Sometimes you have a little bit of tissue, and that will be more precise with the depth gauge. So here is a passage of the ligament. So you will have the K-wire, the wire loop that will take the ligament, and so the wire passer will permit the passage of the ligament. So as you can see here, you can do the same on the tibial side. So here is a picture that shows you how the ligament is going all the way through the joint, and it's good to do a first tension on each side of the ligament, just to be sure that you position properly the ligament. And if you need, of course, you can go back and forward with during the tension that you put. So you keep your tension on each side, and you do back and forward just to be sure that the ligament is positioning well. So most of the time we recommend inside out screw, interference screw implantation. As you can see here, this is allowing us to be sure that the interference screw will be flush to the femoral bone, and to avoid, of course, also some bending effects. So here you can see before tensioning. Then with this video, you will see how you can put some tension on it. You can also have a tensioner. Okay. So here is how you check. So you are going to do some flexion and extension of the knee just to be sure that everything is well positioned. Okay. And so now it's time to lock the implant with the interference screw. So it's very important, especially for the tibia, that you measure properly, because the aim of this technique is to be, again, flush at the tibial plateau. So we want the screw to go through the tibia, the proximal tibia, to go inside the joint. So this time, as you can see, it's an outside-in screw insertion, it's really also easier if you want to go for arthroscopic implantation, because when you're under arthroscopy, you won't be able to implant inside out easily. Okay, so here you can test the tibial thrust, the indirect one, and you can check here that it's not moving. As you can see on the video, here was the test of the direct tibial thrust. And we have here how you can close, of course. You can close the sartorius as you can do it on the TPLO. So for screw insertions, you must know that we've done a retrospective study just to know how much we used. We did a lot of monocortical screws, a few bicortical screws at the time of this study. Now we do much more bicortical ones, because Novetech gave us more length of screws, so that's really nice. And we choose ideally the optimal screw length when it's if you want to be sure that you don't have any problem with the transcortex, you can take a shorter screw. But if you want to go for bicortical, which will be better for biomechanic, as you can suspect, then you should be very, very careful to measure it properly, to take the right screw, and to use a guide, a K-wire smooth guide inside the screw that will guide you to the right position until to the transcortex. So if you don't do that, you might have a fracture of the transcortex, and that's too bad, of course. So most of the time, if you have a transcortex fracture, it's not a very big deal. Of course, don't go further. If you hear a crack, say, oh, okay, I'm just stopping the insertion, and maybe take a shorter screw, or just don't go further if you think that your screw at the cis cortex will not be a problem under the skin. The good thing also is, because we changed the implant many years ago now, this implant is so thin that we reduce the risk of fracture when we do that. Also, the facility of insertion was better now that we choose to do an insertion of the screw before putting the implant. We remove the screw and then we put the implant again and put the screw in. So that is very, very important, because that will be more easy to get in. If you don't do it sometimes with big corticals, it will be very difficult to be able to screw the interference screw. So in this study, we had no fracture of the screw, but we know now that with titanium screw, you should be very gentle when you put tension to screw. You should not do a very quick tension on these screws, because we know that one or two cadaver studies showed that we could have a fracture of the screw. So probably most of the time that was due to the cadaver, because we don't have the same tissue, of course, and the cadaver is stronger and very difficult to implant, more than on live patients. So we did in veterinary school in Lyon a lot of studies anyway. One of them at the very beginning was to define which diagram of screw insertion we could use. At the very first, we didn't use the flush screws, but it was still interesting study, because we defined where was weak points, and we know now that ideally, if you do so, you should take 4 screws. But the most important that we knew here, that the tibial screw insertion was the weaker point. So if we can reinforce this interference screw, it's better. And the most important thing is that you use now, that as we told you before, flush interference screws to the tibial plateau and to the femur, and that's far better now. And the study showed that the tension, the resistance of the interference screw will be better. So we know also that there is a little bit of initial loss of tension that was measured, and this could be avoided a little bit if you do a right position of the ligament. So as I told you before, if you put tension apart the ligament as an implant, and you do back and forward, and you put tension on it, that will mean that you will give the right position of the implant. So it means in reality that it's the shorter way for the ligament to go from the tibia to the femur. If you put some tension when you do the screw insertions, you will find out how the ligament, the implant is positioning anyway. So it's really important to do tensioning during insertion. So now that we use some flush inside-out interference screw and outside-in interference screw for the tibia, as you can see here, it's really far better. So here is a global view of what could be an insertion with 4 screws. And here is a clinical study that we've performed with the old implantation with 4 screws. So it was with 10 dogs from 15 to 85 kilograms. We informed any owner to have a consent form. Most of the time, of course, it was the owners that willing to do something else than TPLO, because they find that it's very invasive to cut bone, and they prefer bone tunnel to like in humans. If we have a failure, we said then that we might do a TPLO at cost if needed. We wanted minimum of 6 months of postoperative follow-up. So the results we had was that the duration of the surgery was 67 minutes skin to skin. In comparison, we had 43 minutes, and now I'm closer than 30 minutes because this study is from a couple of years now. So of course also the duration of the intracapsular study is lower now, far lower, far less than 1 hour. We had no fracture, we had no infection in comparison with the old ligament, the old implant. We had 1 infection, but of course it might happen one day, so just be very, very careful that to have the best asepsy that you can get. We had 2 prosthesis slippage that was not completely catastrophic. On one it was a little bit more, but we had good results. In comparison, we had far more slippage on the old implants. So what you must know that we noticed, but we don't know if it's true, that these slippage appeared when we had a high tibial slope, higher anyway. Functional evaluation at 2 months was subjective. We had no force plate, but when we saw the dogs, it was excellent. Gait for 70%, good 20%, and fair for 10% of them. So the conclusion is that less than 25%, it's excellent. We need more follow-up and cases, of course, and we need also to improve the fixation of the tibial of the tibia, especially, and maybe especially also for tibial slope. That are very important. In fact, so that was a study that was done before we used the flushed screws. But it's good to know that all these things happen, and so now we are moving forward for another study. This one is a retrospective study on arthroscopic implantation on 153 dogs from 1 to 12 years old and from 5 to 65 kilograms. You can see the video on YouTube if you need, and we had, so as a result, so this was a study of Julinder, that is a surgeon that is using a lot this implant, and he had only 3% of major complications, probably as infection, and 5% of minor complication. What you must know is this surgeon is very particular, and his aim is to say we should see how in human beings we are doing post-operative care, and all our post-operative care for TPLO is probably for 2 or 3 months, but that's the maximal probably of all what we do. But maybe 4 months is something more reasonable if we want to have good results. So that was his idea, and he's saying that probably we should go for more post-operative care and control exercise. We have not on this study the tibial drawer. It's not objective at the moment, but they are working on it. So on this year, we are going for forward, and we want to change. We have changed things. We choose probably better the patients. Maybe if we know that the dog is mad, we should say, okay, we are not going to do it. Maybe you can do also, I've done once or twice, a combination of intracapsular and TPLO with partial correction, which is not so complicated. It's really feasible, but I would ask this question. A good technique also is a simple technique. So why going for more and more implants inside? It's maybe not the answers that we want and that we are going to get. But the idea of this is to decrease the tension and to have the good thing, the good part of the intracapsular repair that permits more stabilization of all the knee. We are also working on a new interface system with the Lyon school of veterinary school, and we think it's a really good thing. We are going to have a really better result again, and that will be very nice also for arthroscopic procedure. I would say also that we might think about putting a flow technique just to protect the intracapsular one, or to do an external return, as it is done in human beings sometimes, because we want also, of course, to protect this intracapsular repair. And the flow is nice because we know that for at least 2 months you will have a good stabilization of the knee, and so you can think about it, especially when you have a very big dog or a dog that is completely mad. Maybe you can go for this procedure, but add a little bit of security. For now also we are moving forward because Novetech is giving us some new implants, smaller and smaller again, and we are now I am now doing some cruciate ligament disease on cats and very small dogs, so it's really nice. But I changed again the technique to simplify it a little bit more again. So here is another evolution that I've done, just because we know that the tibial screw interference is the weak point. I decided to use the Novalic button on the tibial side, so that we have an accrued security on the tibial part, but as the screw, as the button is small enough, not too heavy, it's still possible to go through the bone tunnel with an interference screw. So as you can see here on my post-operative rads, it's very nice because we have a double security on the tibia, and then we go up inside the femur. Other cases here that you can see and that I have done lately, these last months, it's an intracapsular, it's a cranial cruciate ligament rupture with a patellar luxation. And I just wanted to prove that it's really feasible and in fact really easy to do. And it was, as you can see here, very nicely repaired with a transposition of the tibial crest, with a possibility of a button, but here is a modification of the technique that I just put a button and no screw, because on a so tiny dog, which is probably 4 kilograms, you might have a fracture of the bone here if you try to insert the screw. Even with a 3 millimeter one. Here is a 3 millimeter screw that we get here. It's now we know that we are going to have the 2.5 screw, so maybe when I will have this, maybe I will try to put the button plus the screw here. So here is a severe strain of the stifle of a cat with a cranial cruciate rupture, a caudal cruciate rupture, and a lateral collateral strain. Again, so this is very particular because I've used just one ligament to repair the cranial and the caudal cruciate ligament with only 3 screws. So, and that was also a very good breakthrough for me because I was able to put the tension between the cranial and the caudal cruciate ligament without having the problem and the troubles that we can get to know if you have too much tension on the cranial or too much tension on the caudal. I did this under X-ray, so the surgery was done under fluoroscopy, but I saw during the surgery that it was very convenient and that I didn't have to manage with difficulty this repartition of the tension. So this is another cat with severe sprain, but much more difficult with a cranial and caudal cruciate and with a medial collateral cruciate rupture, a complete rupture for this time. So this is the axis of the femur of the cat, and this is the axis here of the tibia. So here again, I simplified the technique and I was able to repair the 3 ligaments with only 1 implant and 2 screws and 1 button. So I don't detail, of course, the techniques because for now it's a little bit too early to give you all the details, but we are open to discuss. And as you can see, the IGOS vet reflection group is what we created not a long time ago. It's a group of surgeons, international surgeons, that want to work and develop new techniques with implants for ligamentoplasty or tendinoplasty. So if you want to join us, we'll be pleased to share some maybe some case series with different hospitals. Also, you can do some, as I told you, a partial correction with the TPLO and implantation with screws. So, okay, that was for the cranial cruciate ligament. Maybe we can see Victor if you're okay, we can share the
Yes, Philippe.
the video of the technique very quickly, and then we'll go for the tip and tricks for the ligamentoplasty.
Okay. Sure. Thank you. So you might be seeing the video right now. This is a short 3D animation that will display the dedicated instrumentation for this kind of ligament repair using Novaling, and then the techniques that Philippe described to you.
So I would say this put your insertion distal 3 points totally together. Don't forget to put tension over the ligaments when you do that. So the ligament is the button has the shortest way. And here again, some tension. Before cutting, just check to get first again back the interference screw if you want to put some more tension. And here is a perfect range of motion. Okay, thanks, Victor. So I'm going to... May I share my screen now?
Sure, you can. I think it will just replace mine.
Okay. Okay, so you can see me now. You can see the...
Yes, we are seeing your concurrence.
Okay, so now we are going to talk about tip and tricks and to avoid complications. To know complications of a surgery is knowing everything. If you know where you can have a complication, that's where you will have a good opportunity to be the best inside your technique. So surgical complication that could appear is that you have a poor exit with intracapsular drilling. It will be difficult sometimes if you already put the K-wire to redirect it with the guide. So if really needed, sometimes we can do an inside-out passage of this K-wire, which is possible, but you will have to, especially for the femur, you will have to flex. Of course, you will have to open the joint if it's not done, if you're under arthroscopy, but you will have to do a flexion of the knee, very, very important to be sure to be able to do the right guide K-wire passage. Never forget to compact or tap the tunnel. I am going to describe you what I'm saying about compactage. I don't know, there is no really word for this, but we want to compact the bone with the thread of the screw. So that's why we want to insert the screw first, put out the screw, put the implant, and then again put the screw in. If you don't do it, it can damage the implant, but it would be also, and most importantly, it would be very difficult sometimes to insert the screw. And it might also give you a risk of fracture, which is low, but which exists. If you have a poor choice between tapping and compacting, okay, for now, we are only compacting with this device. We have also some PIC screws, which are not really available now anymore. But when we've done some PIC screws, we had to tap. We don't want to lose some substance, some bone substance, so we don't tap with the titanium screws and for all the screws that we have. If you want to, you can tap only the very smallest one. For the 3 and 3.5 and probably the 2.5 that is going to be available soon, you can tap. It's probably a little bit less important, but I would say that for my opinion, I will always compact even for a 3 or 3.5 millimeter screw. So the idea is you are going to crush a little bit the bone, and that will reinforce a little bit the interference because you have more substantial bone here. For me, it's essential if you have a large size dog. If you do a wrong insertion of the screw, if you lose the axis, so please always be very, very technique. You must keep your axis. If you use a ratchet screwdriver, that will help a lot. And also, if you be very careful that you have a line between the K-wire, the screwdriver, and your hand, and then your elbow. If everything is aligned and you're screwing like this, you will have a better axis, and you will not be wobbly around the axis. So, because if you don't do so, you will have less contact at the interference screw, and that will be not very good for the resistance of the implant. You will have a loss of tension and an early tibial drawer, so that we don't want, of course. So always insert a K-wire into the cannulated screwdriver. That will help you. The screwdriver, so everything is important here, of course. If you have any trouble with this screw, and that you find that it's too easy to go through, maybe you can take out the screw and put a bigger one. Always put the bigger that you can, but we don't want a fracture also. So you just have to have a feeling of what is normal or abnormal. If it's too easy, and of course, the more cases you will do, the more feelings you will have. But it's always important to be very careful with this sensation that you will get. I would recommend also not to use a motor to screw the interference screw, because it's too risky. If you have any difficulty for the passage of the prosthesis in the tunnel, you can reverse the pull wire. You can also squeeze the traction cone with a kosher clamp or anything that will squeeze this traction cone. Also, Novetech is working to improve a little bit more the cone. But I would say that with the new implant, we have very few problems to insert the implant through the bone tunnel. If you have poor tensioning of the prosthesis, you must know that you could have an initial loss of tension, and you might have a drawer during surgery. So that's why we recommend to go for flexion and extension, cycling flexion and extension, just to be sure that the position of the prosthesis inside the tunnel is good. Just always maintain the tension through the tunnel when inserting the screw. And we could also recommend sometimes to insert the screw, the final screw. Of course, the femoral screw is always inserted in flexion, but you can also insert the tibial one with a little bit of flexion, because we know that when the stifle is in flexion, we have less drawer, and the femur is more cranial. So that might be a good thing also to avoid these problems. The weakest point of all the fixation is the tibia. So if you want to, you can do like I've done, using a button on the tibial part and putting a screw. It's possible. You have to check the bone quality, of course. If the epiphysis is looking with a low density, you should maybe avoid this technique anyway. If you have an infection, you will have an ovalization of the bone tunnel and loss of adhesion with a slippage. So that will need probably a revision surgery with any type of surgery that won't use this technology, you must prevent any infection with a very good asepsia, with like if you were doing a total hip replacement. We don't know about bone resorption over time. Of course, it's possible, but we think that the fibrosis that will come with time will counter this action and will still keep the implant in place. So here is how I work with a lot of precaution, just to be sure that we don't have any contact with the implant and the skin. So if you have a sliding of the prosthesis, or that's a complication you could get. It's so the prosthesis is sliding. You can have a little bit of residual tibial thrust, especially if the dog is going for gallop or jumping. That's why I would recommend, if it's a mad dog or a very big dog, maybe to protect the intracapsular repair with another thing, probably a flow or a lateral return. The rest, of course, and the leash walking is very important and must be very strict. So just talk a lot with the owners, of course. Physiotherapy, if there is a little bit of sliding, just maybe 15 days after the surgery, you should go in your program of physiotherapy 2 weeks before in the table, if you have one. I do, of course, and it's good for the owners to know how long they can leash walk their dog any day. So if you have a slippage, you should go 2 weeks before, so at the very beginning of the program. Something I recommend also is a cryotherapy brace. It's a compressive cryotherapy that I'm using on any surgery I'm doing on knees, elbows, or tarsus, because it's very easy to use them, and that is avoiding edema, inflammation, and it's anti-inflammatory. It's really, really good, and it's proven by many papers, especially in humans. If you have a synovial leaking, you must always be very careful to the closure of your capsule. If you opened it, you can use, if you have a leak, maybe you should go for PDS or polypropylene, maybe with big diameter for large animals, and do single stitches if necessary. I'm saying that because we had the question once, so of course it's not happening a lot. If you have seroma, just be careful and sure that you have sutured the sartorius independently of the subcutaneous plan, just to be sure that you have multiple plans at the end. And of course, you should go for arthrocentesis, bacteriogram, and antibiogram, of course. Just to be sure that you will get the good antibiotics if there is any infection. If you have post-surgical meniscal injury, I want to know it because I have not seen anyone to date, but of course it might happen. It will happen probably one day, but my feeling is that maybe it's a little bit less than TPLO, but we really need more cases to be sure of this. Okay, so we are going to talk now about the hips. I'm probably going to move forward because we have still all this to show you. Probably after you will be able to ask questions, and we will be able to talk about all these surgeries. So hip luxation, I wanted to show you first the anatomy. Everyone knows that, but it's important to see the fovea ligament, the joint capsule, the little muscle articularis cocci that is on the capsule, and also the little transverse acetabular ligament that we can see here. The existing procedure that I've been based on to create the new technique was tubal pin fixation. The aim is to replace the fovea ligament, and so you know probably this technique, and it's well described. The problem of this technique in the literature that it's giving some luxation, some reluxation. We have from 5.8 to 13% of dogs that are reluxating after surgery, which is not it's not nothing. It's something that we are all aware, and that we are anxious with that. So that's why I wanted to have a better surgery, something that would hold better with a better ligament and better interference, and that's what I'm going for. So I wanted again to do studies of cadaver studies, CT scan, clinical studies, just to evaluate everything that we could, and to show you the surgical approach first. So at the very first, we didn't have the button. So the technique, when I did the first case, it was in 2014, I think. So it's a lot of time now, and I had to do an approach that was very different. I will still show you this technique and this approach, just because in some cases you will have a problem with the back of the acetabulum. In some dogs, it might appear that the acetabulum is too weak for the button to hold. If it's the case, it's nice to know another technique that will permit you to put the ligament differently. But that was the initial technique that I've done, and after I modified, of course, when Novetech gave me the button, that's of course simplifying a lot the surgery. So I need a technique, a surgical approach, just caudal to the rectus cranial to the caudal to the rectus femoralis, with a curved periosteal elevator, and we do a protection of the obturator nerve. When we do that, of course, you go to the bone and stick to the bone, as Fitzpatrick told me once when I was an intern with him. So it's very important, stick to the bone and you won't have any problem. Here you will see the cadaver study with the aiming guide that is evaluated, and we showed that the repeatability was very, very high, with hundreds of out-in tunnel that was inside the fovea capitis, and we had no cortical infraction of the femoral neck. But for this, you must know how to do it. So you must put the hook inside the fovea capitis, and also you must do a little dissection at the very end of the greater trochanter that will allow you to be in the axis, as you can see it on the CT scan, in the axis of the femoral neck, so to avoid any infarction. So here is another step of the surgery. It's the acetabular tunnel. You can do it directly or indirectly with through the femoral tunnel with the position of the femur at 45 degrees. And it's possible to go inside the acetabulum without being inside the cartilage surface. So, of course, you have to avoid it. Here, you can see a little bit, I hope you see my little mouth here. You can see the cartilage surface in orange, and the black hole here is what you aim. I recommend to regime the acetabulum, and then to drill in the center to be sure that you will have the best biomechanic. Then, if as a drill bit, I would recommend to use directly the 4 millimeter drill bit if you are going for the button insertion, because the button will need the 4 millimeter one, so you can use it directly. So here is a hole that you can see with the orange arrow. You can see here the hole on the back of the acetabulum, and the prosthesis after is going through, going along the ilium surface medially, and go inside another tunnel that is perpendicular. And then the interference screw is doing the job for holding the implant. Now we don't use anymore this screw. Just if you don't have any choice, you will use it. But most of the time, we will use this button that is going here, and that is holding the prosthesis with. Okay, so you have here the acetabular tunnel with the identified risk, with the potential of tunnel ovalization. That was a risk, and that might go for a loss of the tension. The prosthesis rupture could be caused by abrasion, but our hypothesis, because we never had any case that showed that we had any problem like this, is that articular capsule healing is faster than ovalization, and probably that prosthesis design is very abrasion resistant, so that we should not see a rupture of the implant because of the passage on the bone. So we need to carry on the study to have more answers, of course. So the length of the ilium fixation might have been a problem also, but we verified this with CT scan, and we find it was acceptable. And this hole, this bone tunnel, was cranial to the acetabulum, just at the level of the rectus femoralis that you can see here. So the aim is, with the first technique, was to take the wire passer to go through with the prosthesis, as you can see here. But with a new technique, you take the button inside a little coccygeal clamp, or with a long arthroscopic clamp, which is much better, and you will put it inside, well, on the medial side of the acetabulum, and then you will lock it. So just always verify that the button is really locked, because if not, it's going to go to lose all the tension, of course. So the perpendicular, so we had, as you know, a bone tunnel inside the femoral head through the femoral neck. We also do, for the interference screw, a perpendicular bone tunnel in the femur, because we'll have a better cortical. When you are in the epiphysis, the bone is very weak, and so I do not recommend a screw inside here, also because you can have, you might have a fracture when inserting this screw. So we prefer a perpendicular screw, which we know for sure, because it's proven by papers, we have a better traction resistance when we are at 90 degrees. So that's why I recommend this. And most of the time, the best is to do a caudal to cranial drilling, and also a cranial to caudal implantation of the screw, just because it will be highly easier to protect the sciatic nerve. So here is the final view when you don't use the button. So that was the old technique. So the ligament is going all the way through inside the perpendicular bone tunnel, inside the femur, and also inside the ilium with a perpendicular bone tunnel. But now we are using with button the technique, and so when you see it, now we have the button on this side, the ligament, and again the ligament through the bone tunnel, and on the medial part you can see how it works. So surgical indication, I would say that we can use it on acute luxation, so either craniocaudal or ventral luxation of the hip. Why? Because with ventral luxation, as we have a replacement of the ligament, that will hold. And that's the really good thing, is that with this technique, you will be able to treat ventral luxation of the hip. You can use it also when you have a luxation and the dog has a background of dysplasia. We had some cases of this. Of course, we recommend that this dysplasia is moderate. The good thing is when you do the surgery, you will have to evaluate the femoral head and the osteoarthritis. Of course, don't do it if the head is completely without any more cartilage, or if you have a coxa plana. It doesn't make sense. But if it's really moderate and you are able to implant, you can go for it. We had very good results in some of our cases. We can use it also with chronic luxation, at least 3 to 4 weeks. To date, most people say that we shouldn't use it, we shouldn't do a reduction, even a surgical one, with chronic luxation. In fact, what I've seen into my cases is that sometimes you have, most of this time, you have a scalp of 1/5 to 1/4 of the femoral head, but it's on the ventral part. And the ventral part is not a contact, is not a cartilage that will be in contact when the dog will be walking. So hypothesis when I've done this surgery, because at this time for this dog, this particular dog, the first dog that we've done, we didn't had any choice. This guy didn't had any money, and he just had a very few money. And the thing is, we were not going to be able to do other surgeries as total hip replacements. And the problem also that this dog was a working dog, and this guy really needed this dog, and he wanted, if it was possible, to replace, to put the hip back. And so we've done it with good results, and we've done it on other dogs now with other good results. You should also go for adult dogs, just because think about the acetabulum. If it's not an adult, the button will go through the acetabulum, because the acetabulum is very weak and it's not going to hold the button. So don't do it on the puppy. Okay. So I did a first study beginning in July 2014 without button. We had some dogs that had traumatic hip luxation, and we informed owners for consent form. We had substitution surgery at cost in case of failure, and a follow-up of 6 months. In all these dogs, we had 4 hips dysplasia, moderate, but still there. We had 2 hips with 1/4 of the neck missing by chronic friction of the ilium, because it was a craniocaudal luxation, and we were 3 weeks post-trauma. So it was an owner demand, that's why we've done it, but I would recommend it if the rest of the cartilage is good, you can do it. So it's excellent results and very premature functionality. I would say the hour following the surgery, the dog is able to walk, of course. We had no luxation recurrence on these 15 dogs. We had no infection to date. So please follow a total hip replacement follow-up for the aseptic, for the asepsia. We had 1 laxity at Buttin test, but no functional difficulties on 1 dog, and we had no osteoarthritis at 6 months. I would say no more that it could be noticed on the first x-rays, but as everyone knows, the evaluation of osteoarthritis is never easy. And X-ray is not the best way probably to evaluate this. The clinical study that I've done after with Buttin, so we had 1 hip dysplasia. We had again excellent premature functionality, no recurrence of fixation, no infection. And of course, we need more case and more follow-up. That's why I would be very happy to have some of you joining us the IGOS, so that we share some cases, and maybe we build big case log that might be published one day. So that's post-operative rat that you can see with Buttin. And you can see the coaptation that is very nice, very good, and range of motion was also complete, and that's a little bit of difference that you can get when you use extracapsular prosthesis for hip luxation. I don't really like it, because you have a little bit of diminution of the range of motion, And also you are always, I would say, worried to do flexion and extension of the dog, to do physiotherapy, because you say, oh, it might break, I won't touch this hip until it heals. Here the dog is perfectly well at the very beginning, and it's very easy to do physiotherapy. So we have very premature remobilization. We have a control exercise for 6 weeks, anti-inflammatories 1 week, and antibiotics. So the conclusions and tips that we could give without and with Buttin is, so the good thing is we don't have any recidivism, reluxation, despite some dogs that had dysplasia. We had positive results even when we had ventral scalp of the head. We verify always the articular capsule as well as the coaptation before you close, because, so that's a tip. If you don't remove all the remnants of the capsule, you might have a wrong coaptation, and that won't be because you didn't put the implant correctly, or that you put the right tension. It's just because you have something that is in interference between the two cartilage. So you must check that before you close everything, and you must check that everything is perfect as a range of motion. With the Buttin, always test the Buttin, that the Buttin is locked behind the acetabulum. I always put a lot of tension in some dogs that has maybe 15 kilograms or 20 kilograms. I'm able to lever the dog out of the table with the implant most of the time. So just to show you that it should be really locked. Okay, so I will up the sharing screen, and I will put back, okay, the video. Maybe you have some questions, of course. I guess so.
If it is fine for you, I just display the video and we can go through the question after.
Oh yes, of course. Sorry, we need the video of the hip, of the technique.
This is a 3D animation of the hip techniques that Philippe described you with the Novaling with Buttin. You will also see that the instrumentation is similar. It's the same one that's the one that is used for CCL repair.
So you don't have music on this one, Victor?
I don't, but I can put it.
Okay.
It's relaxing.
So again, this aiming wide, all the screws that you can find now. We have more of them. We have smaller ones. So we have also the 3.5 and the 3. And in a few weeks, probably we'll have the 2.5. So that's a Buttin that we use now. It's mandatory to have a simple surgery. Of course, again, sometimes the acetabulum might not hold, so just be very aware of this. So this is implantation of the K-wire first. It's a K-wire with Okay, and this is a cannulated drill bit. So as you can see here, the spot of the insertion. It's very important that you be precise on this, and then you do the perpendicular one a little bit distally to the first. Oh, this guy is very quick. And then you put the K-wire that is guiding you. You put the screw in and you put it out completely. We want the thread to be done already before insertion of the implant and before insertion of the last interference screw. Sorry. Here is the acetabular bone tunnel. So you will take the button, put it with the forceps inside the hole. It's not, sometimes it's a bit difficult if you don't put out the remnants, so that's why a regime is nice sometimes. Then you take the implant through the femoral head and then you reduce the hip. And then from cranially to caudally you take the implant. So the implant is going caudal to cranial. You're putting a kosher clamp that is curved and that is allowing you to put more tension on it. Here is the last insertion of the screw, and it's done. Thank you, Victor. So I would say that, of course, it's really important that you, if you can, you have a technical formation with the cadavers. We are doing some formations at ECVS sometimes, so you can try to get some of these. All the tip and tricks is not just we try to give you everything, but it's always difficult to be sure that you will get everything. So showing you is the best, but because we have a lot of difficulties these days with the COVID, as you know, this disease is a nightmare for Congress. We performed some videos of all this technique with Novetech Surgery in collaboration, just to show you everything in details, so that you have every step defined and in video. So maybe Victor can tell you about this, but you can get them on internet.
Sure. Thank you, Philip, for all these conferences on both techniques. It was very dense. There was a lot of information, and thank you. That raised some questions in the attendance, and I will try to get through them now. There was a question from Dr. Odman from Sweden, who asked you about the CCL technique. Do you flush any antibiotics on the fiber just before it is inserted or not?
Okay, I do not, just because we have no proof that it can hold on the fibers. The big problem is that we've done some studies, for CT scan, and we tried to put some iodine on it, and we tried to put some other product, and it's very difficult because this implant is completely how I would say
Hydrophobe?
Hydrophobic. It's very, very strongly hydrophobic, and it's very difficult to insert some. But of course, you can do it. It's there is no wrong, nothing wrong to do it. It's just that we are not sure that you will get any thing inside it. But you can do also some local infusion if you want to.
Okay. There was other question from Dr. Mitrakos. You talk about a tibial drawer that was not objective yet at the moment in the post-operative. What do you mean about this sentence?
It's just because it's not my study, and so it's a Jullinder's one. And for now, we don't have all the X-rays and all the manipulations that we want at 2 months, 4 months post-operatively, and we need really to compare it. It's mandatory for us to have something very strongly
Evidence-based?
scientific and evidence-based, and we really need these information. So for now we don't have them, but for what we know, the results are good also for this tibial thrust. That's the opinion of the surgeon, but we really need some more information about this.
Sure. Okay. There was another question as well from Dr. Mitrakos. When you place the implant and you start tightening until you lose the cranial drawer, do you need the stifle into a certain angle?
When you put some tension?
When you are tensioning the prosthesis.
Yeah. As I told inside the conference, you might put some flexion on it, especially, I would say, especially if the dog have a very chronic cranial cruciate ligament disease that is for many months, is sometimes 1 year. The fibrosis is so big that even if you put some tension, the femur will be a little bit caudal. So if you want to avoid this, a very big flexion of the knee might counter this action. But for most of the dogs, I don't do it. I just do it in physiological angle. So it means 120, 30 degrees probably.
Okay. And I will maybe get to the last question who arrived on CCL before switching to the hip. A question from Dr. Berg from Norway, who has experience in the CCL intra-articular reconstruction and did 45 patients, and has a question about the slipping of the ligament. So the 31st patient was done with Z-lig, so with cross-screw, and he got 2 sliding on the 45. And he is asking if you think this could happen because of thermal pipe drilling, that the screws are too short or false produced. He added that now he got the Novalig material and will implant some later.
Could I read it? Because I'm sorry, the question was very, very long. Do you have any idea how I can get these questions?
On the right side, I think you might have access to the chat. On the top right side, there is chat, polls, people.
Okay.
But they do have different screws. The screws are very different to ours because ours are a lot sharper. And also, depending on what drills they're using, we have the 2.1, 2.2 mil sharp K wire, don't we? As well. Can you see that, Philippe? Can you see that, his question under the chat? Philippe's frozen.
Philippe, we lost you.
He's frozen somewhere in France.
Philippe, can you hear us?
Oh, now he's disappeared.
Oh.
He'll come back in a minute, I guess. Yeah, he's lost his internet connection.
Sorry for that. It seems it's like the live kind of issue we have.
Well, at least it's at the end rather than the middle. So
yes, we can take this time as an opportunity to talk about IGOS. Philippe talked a bit about this and the training we do on cadavers and so on. There is many options for you to get deeper into this kind of solution, to speak with other experienced surgeon, or to travel when it will be possible to congress or university where there is hands-on training on this kind of solution. So feel free to contact Karen or Novetech, depending on your location, and feel free to get on the IGOS website as well. It's igos-vet.com. It's completely free of charge. It's just a group of surgeons working together and sharing experience. So have a look to it. Get on board if you want to or not. Just have a look. So Philippe, you're back with us.
Yes.
Can you have a look to the chat or not?
Yes, I can see it now.
Okay, so we will take maybe a last question with from Dr. Begg on the CCL, and we then goes on hip because the time is flying. So Dr. Begg had 45 patients operated. He got 2 sliding and is looking for hypothesis of why he got this sliding. If you have any.
So he says he's using free fibers now.
Yeah, exactly. The 45 patient was done with free fibers.
The problem is we don't know. The free fibers might be a problem sometimes. We use them before, so we know, we experience them. The only thing is, I think he is the only one that could respond by doing a revision surgery, because when you go back, sometimes you're able to identify the problem. It happened to me sometimes to say, oh, that was the problem. It's not always easy, of course, but sometimes you can say it. So if, of course, if the ligament is broken, you can see it. If it's only a sliding, I would say that for now, it can be just a powerful dog that just done something crazy, that is overloading on the ligaments. Probably we might have the same problem with our product without free fibers. So I would say that it's really difficult to know it. The very important thing is a technique to respect the fact that you have to be flushed on the tibial plateau because the cortical is better, and also on the femoral side you will get some very, very good holding there. But okay, I don't have defined answer to this. It's really difficult to answer.
Okay. Thank you. So in the meantime, we just had question on the side of the smaller side of the interference screw, so I directly answer them into the chat. So at this time, the smaller interference screw are 3 millimeters. We are working on smaller. Maybe we will be able to go up to 2.2 millimeters, but that's for later this year. There was question on the hip and articular technique you described, Philip. There was a question from Dr. Wu, who asked,